is symptom management.
Okay.
And that can work in conjunction with people who are still undergoing chemotherapy, treatments, things like that, but they're having a lot of symptoms maybe that aren't that well managed, and they're having some discomfort or whatever is bothering them. That's when palliative care is appropriate. It helps to overlap to make that part of your life better. And now hospice care also goes along with palliative care, and it's really the basis of hospice care, is helping you to feel better physically, so emotionally, psychologically, and spiritually, you can start to process things for the time that you have left. And can I say that everybody will reach a point at some point, unless you're hit by a bus or something sudden like that you die from, that you'll have a little bit of a heads up. A lot of the people that we see have illnesses that have been going on for years, and eventually that disease will take your life. And people in hospice care just happen to have a heads up that this is what's going to happen, and they really are taking control of what they would like to do.
So I'm thinking there's a real bright line that, okay, we're going to cure me, fix me, whatever, and it's not working anymore, and okay, now boom, but there isn't necessarily an absolute, okay, now it's time. Maybe there is a grace period where maybe we can just keep your symptoms under control, and things aren't getting worse, or you're sort of stable, but you're still eventually going downhill because of this ailment. Some heart problem, some respiratory problem, a cancer problem.
Right. It used to be, and a lot of people still think that in healthcare, your decisions really are either or. And it's either you are pursuing treatments or you're stopping everything and going to hospice. And that's where palliative care really is a nice bridge between those two, until you really get to the point where physically you're not able to do treatments anymore, or you're tired of treatments. But in the meantime, you've had the beginnings of hospice care in palliative care. So
the treatment may not be working at all, but maybe it's helping a little. Maybe it's helping with, the tumor's not getting any, it's not going away, but it's not getting any worse. It's staying the same with so I'm going to keep going with the chemotherapy.
If you want to. You don't have to. Some people do. And there's no right or wrong answer for people and things like this, because deep down people know, or have the idea that if I stop these treatments, I know I will die. So I really need to pursue this because I'm not ready to die. But it's the idea in the back of their head that if they stop that today or tomorrow, they will die. And that's not necessarily the case, but a lot of people have a really strong psychological connection with these treatments and keeping them going, whatever the cost, however lousy they feel. And that's okay if that's what they want to do, but that's where palliative care can make them feel better in that meantime. I've talked to a lot of people that never got to the spot in their minds that they were ready to stop active treatment. And that's their choice, but in the meantime, you can feel a whole lot better.
Maybe even you told me, but folks involved in hospice type care tend to live longer than folks who are, we're going to save you, we're going to save you, we're going to save you.
They really do. They do.
Why? I mean, that doesn't sort of make cognitive sense. I'm sure it makes sense because it happens, but...
Well, consider this. Chemotherapy is notorious for making you feel sick and wiped out and just lousy. And if you are so laid out with nausea from the chemotherapy, and that's not to say that everybody getting chemotherapy, disclaimer here, is going to feel that lousy, but you can. And I've seen people just can't even roll over in bed because of nausea that they've had. And just some simple interventions helps that nausea. They're able to eat some. They are feeling better. If you're feeling better physically, mentally, you're going to do better too, because you have a different outlook on life right now. If you're not so exhausted from being sick, you're sleeping better. I mean, all those things add up to creating a better quality of life at that time.
And hospice and palliative care is really the secondary support to the primary caregiver. So when you, even post-surgical, you receive palliative care to a point. When you have your surgeons and you have everyone in there really keeping an eye on that incision, infection, post-surgical wounds, at that point, palliative care can be that enhanced care, that extra step to really maintain those symptoms following your disease process.
Let me take a step in a different direction here. I have a surgery on my shoulder this past year around the holidays time, and everybody was asking me, does it hurt, not, your pain pill, pain medicine, whatever. It's like, I know it's okay. I mean, from where I was at, with the whole process. I'm going for my physical therapy or whatever. I know it's going to hurt, and I'm okay with that. I want to get this over with. I'll work a little too hard to make it hurt more if it gets me done and back to sort of 100% normal.
You're a tough one.
Sooner. No, not necessarily. But it's like I tried to put the surgery off by doing therapy and stuff ahead of time, and it was a couple of years, but whatever. I had to have it anyways. So it's like I know it's going to hurt. Something got fixed. That's going to it's going to hurt, but it's okay because I'm getting better in the end. Okay, the other side of that is the pain's debilitating, or I can't do anything else because of the pain. And I'm thinking to my grandmother. I told you this story before when we were talking about hospice and grandmother, and she'd had cancer, but she recovered from that and lived a nice long life. And when she was in the hospital for her last visit, there wasn't any other choice. It was you go in the hospital, and she asked the nurse if she could have some tea, and the nurse said, "You're too sick to have tea," and she died. And it's like, what's the difference? If you're going to die, have the tea if that's going to make you happy.
Exactly.
Right? Let me just start that one in general.
We get asked that a lot.
Do what you want. Right?
We get asked that a lot.
Yeah.
So regarding feeding tubes and aspiration, and do you get a feeding tube or do you aspirate? It's families have those difficult decisions, and really what we're finding is they might not be having those conversations with their physician, or their physician might not be initiating that conversation because, recently we read up a lot on upcoming hospice and palliative care and research is showing that physicians might not be initiating those conversations because they don't want to give up on their patients. They don't want their patients to think they've failed, and it's not about that. It's about changing the outlook of the prognosis. If you have a life-limiting disease, and you feel that signing up for hospice will make you lose hope, it actually just refocuses that hope. So, say for instance you were hoping that you would be at your grandson's graduation. You might shift that hope to maybe being there in a different way by writing a letter or making a video or something. So hospice really helps you with that journey at end of life and those end of life decisions. It shows up for people differently. And, we talked a little bit about, I was talking to a provider yesterday about hospice, and he kept saying, when your patients go to hospice, they start on hospice and then they go to hospice. I had to actually explain to someone in healthcare, states away, mind you, but that hospice comes where you are. We were talking a little bit about that, Jennifer. You have a lot of experience with that because you actually go to these folks' homes and nursing homes. And
in a rural area like this is a far cry, the hospice care that's provided, than a city. Mm-hmm. And he was from California or something like that, I believe. So it is very different picture here in Northwest Pennsylvania of what hospice is, just geographically, economically. We see the hospice is really an agency with different types of professionals seeing that person. Home health aides, a social worker, the nurses certainly, with the backup of pharmacy and spiritual care and all that. It's an agency that goes to where the people are. It could be their home. We could see somebody initially at their own home. They can't do it there anymore, so we go to their daughter's home or the nursing home or the Marquette Hospice House, or wherever you are calling home at that time is where those people follow you to. Mm-hmm. And it doesn't necessarily have to be a place where you physically go. That is the hospice. The hospice is the care that you're receiving.
Let me finish. I wasn't asking my question to you, Jennifer, very well before, but I'm thinking about my pain situation. I had surgery. Everybody knows that's going to hurt. Mm-hmm. I didn't like the feeling from the pain pill. I didn't feel. I felt cloudy. I wasn't. I didn't like that at all. It's like I want that to be over with. I'll have a little bit of pain rather than that. If my situation is, I'm further along and I'm nearing the end of my time, we can probably deal with my pain. Okay, I think it says right on the package from the pain pills that this may be habit forming, whatever. So it's like, okay, as soon as I take the last one of those, it'd be too soon for me. I don't want to get. We don't worry about that. The symptoms are what matters.
The symptoms
not
is
the
what
other
matters.
stuff.
Yeah. And just because you have a shoulder pain doesn't mean that is going to be treated the same. To treat it appropriately, and that's part of working in hospice and palliative care. You don't treat a shoulder pain the same as you would diabetic foot pain. It's different medications. It's just not more of the same narcotic to essentially shut you up. There's a lot of different options as far as what is the best approach to the pain. And I've had a lot of people in your situation that they don't like the feeling from that, and they'd rather hurt a little bit and be more alert. And really, it's up to the individual. I've had people tell me they don't want to know a thing, they don't want to feel a thing, just knock me out. And we've had other people that absolutely refuse pain medication for whatever reason. It's whatever the patient wants. With your instance there, you know, maybe a different pain medicine or an anti-inflammatory or just some ideas might have been better for you with less side effects like constipation, nausea, cloudiness, feelings like that. You should have called me up.
Well, you know, when you know, doctor cut in there and stitch things back together and whatever, that's going to hurt for a few days. No matter what else you do, that's going to hurt, you know. So, okay, we'll put up with the foggy feeling, you know, for a few days.
But fast forward, because most individuals with life-limiting illness are over the age of 65. So fast forward to being 85 and feeling that pain. You know, we assimilate medications differently. We feel it differently throughout ages of our life. So hospice can come in and manage that because what works for you now, Dwayne, might not work for you in 20 years.
And depending on what's causing your pain or your particular illness, if you have end-stage liver disease, we have to be mindful of the things that we're offering to you. If you have cancer that's spread to your brain and your bone, there's a lot of things we need to be aware of too. And that's where an earlier even consultation or even earlier palliative visits are helpful, because we explain the differences to the patient and their family, give them ideas, say this is what's going to happen, here's what we can anticipate is going to happen based on the course of your particular illness as an individual. Here's some ideas to chew on. If you have questions, please write them down, call me back. And I often invite, when I do have a family meeting, the more the merrier, you know, because these people are under such a crush of what do I do now? I don't know what to do. Their own internet research, you know, and those questionable sites sometimes. And so I just say, whoever that you think you might like to be there, because the more ears that are hearing what I have to say, the more people are going to hear and compare notes. It is impossible for me to talk to somebody about end-of-life issues and explain everything and have them comprehend, understand, and get everything that it is I'm trying to say in just a short while. And that's why we really rely on our nurses then to follow up, to reinforce and re-explain, and we have people available to answer questions anytime.
Let me follow up on one thing you said about, you used the word earlier. And I've been on the hospice board for a number of years now, and one frustration, I think, with some of our staff members is we get the person and they've lived 1 day or 2 days or just made it through the weekend or whatever. Yeah. They really didn't get a chance to get that benefit. I mean,
that's absolutely true.
I think of hospice as, yes, we can't save you, but that doesn't mean that there isn't positive things that can happen. You want to get everything settled with the family, and you want to pass on wisdom to the grandkids, whatever it is, whatever it is. And if you come in at the last second, there isn't going to be a chance to do all those kind of things. What is the right? Is there a right time? I mean, what is earlier? What does it mean?
Well, and that's where palliative care, not to keep jumping on that, you're feeling better. You're still continuing. You get the news that the treatments aren't working, but in the meantime, you're feeling better, and it's a natural segue. You had physical therapy for your shoulder, and that was the most appropriate care for you at that time. And there comes a point, literally, where hospice care is the most appropriate care for what's going on with you. If you're not going to get better, if you're not doing treatments, if you are going to die from your particular illness, all hospice really means is now we're shifting gears to the most appropriate care for you at this time in your life. If you're pregnant, you have maternity care. And people have a hard time mentally thinking of that because they know it's end of life. No one wants to die, but this really makes it a whole lot better. And people are better prepared. They're able to get on Facebook and look up people they always meant to from school. They are able to call maybe a son that they haven't talked to for 30 years. They have a heads up, and they're feeling better, so they care enough to be able to do those things at that time.
The bucket list stuff.
That's exactly it, yeah.
Jennifer, we talked recently about a family that you, through your certified hospice and palliative care certification, you've had that for a while.
A little over a year, yeah.
You mentioned how that changed your approach with families. Tell me about, I'd like for you to tell the folks about that intervention with the one family.
Well, luckily for our patients here at Meadville Medical Center and Hospice of Crawford County, since we're involved, we do offer inpatient palliative care and inpatient hospice services if that's necessary. We had this lady, very, very ill with cancer, and really her pain and nausea, really anything that you could be experiencing was out of control. And she literally was within the last days of her life, and everyone knew it. She just was not comfortable, to the point that her kids were frightened to visit her, adult children. They just couldn't take it. So was asked to make some suggestions, did get that pain under control. She was able to go home to be with her dog that she had missed terribly, and died very peacefully with her family. And the family had time to come in. They from Pittsburgh, some outlying areas, and it was really a testimonial to what hospice care should be. It just worked perfectly, and it's just amazing to know you have some that kind of impact on not just that person who's dying, but that family. I mean, what a difference in their memory now. Mom was screaming in pain, and I couldn't take it, so I wasn't there at the end, versus, and Mom was sleepy, but she cracked her eyes, and she held my hand, and it doesn't have to be that way. It can be so much better. People just get over the hurdles in their minds. Ask questions early before you ever think that you might need this service. I'm in my 40s, I don't know what's coming down the road for me, but certainly now is the time. And we ran into these same kind of mental obstacles when advance directives first came into being. And now everybody and their brother has an advance directive. They're saying very clearly, I do want that, I don't want that, and it's very well spelled out lots of times. Initially, people were under the impression, if I have an advance directive and I don't want CPR, if I go to the emergency room, they're just going to stick me in a corner and let me die. And people know that's not the case now. And this is the same with hospice care. Thanks.
If you have, let's talk about that a little bit more. How do I start that conversation with
anyone,
ill relative, or family member or friend or whatever that's, it's not getting over this hurdle or not? How do you start that conversation about what care do you want? And is palliative care right? Is hospice care right?
I think you try to initially, in your own way, find out where they are in their disease process. I think it's important before you start a conversation with someone to understand where they are, and you might need to think about your approach a little bit more. But you want to understand where they are, if they're okay with the diagnosis, if they're aware of the diagnosis. Some patients are not aware. Their families hide it from them. So it's interesting that, from the social aspect of that, find out where they are first, and then as a clinical aspect, you would probably want to offer some tips on that.
Sure, but even if you're just sitting around the dining room table yakking like people do, hey Mom, if it ever came down to it, you had a really bad stroke, what would you want me to do? I've heard stories about, people that have had to make the decision to take their mom off life support or make these decisions, and I really want that time, if it ever comes, to go the way you want it to be. And they're not comfortable conversations to have. They can be very hypothetical, hey, you get a really bad infection sometime, or you're stuck on a ventilator, or what would you like? It can really be as open as, hey, I want to paint the living room. What colors do you think? In a different, non-threatening type of way. But it really is helpful to families if people do express wishes of what they would like.
I had that experience myself at a family funeral and mentioned to my other family, what would your wishes be? And and that person sort of, I hadn't really thought about it. And it's now made all the arrangements and prepaid for things and all,
It's not something you really think about.
I didn't intend,
right.
I wasn't trying to start, the ball rolling or anything like that. But I suppose it's a positive thing to do, and maybe, some other event gets that ball rolling sometimes.
Right. You'd be absolutely shocked when I go to talk to people about hospice services and things like that. And they're interested in it because they know this is what they need. And I ask them, so in the event that your heart would stop, do you want CPR done trying to bring you back? Knowing it doesn't change everything that's going on in your body now, that the reason that I am here. You'd be stunned at how many people have never been asked that question. Or if they've been asked it, they've blown it off, not taken it seriously, and not considered, do I want a feeding tube? Do I want on a ventilator? And CPR is not like what they show on TV at all. And these things, people really need to educate themselves. well in advance of needing these types of services.